Hola, muy buenas tardes a todos.
Hi,
Espero
everybody. Good
que se
afternoon.
encuentren todos muy bien,
We hope everybody's doing very well,
preparándonos ya para nuestras festividades
preparing for
patrias
our
y para estar obviamente con nuestros familiares,
national
amigos y
days and
descansar.
to share with our families and
Que se
friends.
encuentren todos muy bien.
We
Quisiera
hope
dar las
everybody's
gracias a los
doing
auspiciadores
okay.
que
I
nos
would like
acompañan
to thank our
para llegar con
sponsors.
ustedes a estas charlas. El día de hoy nos acompaña Conmefarma y Web Mental que hacen posible esta transmisión. Antes de iniciar la charla de hoy, vamos a dar, ¿cierto?, unas cápsulas comerciales a nuestros auspiciadores para luego, ¿cierto?, empezar con la charla de hoy.
Años informando a los dentistas de Chile y el mundo. Entrevistas, fotografías, sitio web de noticias, cursos, videos corporativos, simposios, periódico, impreso y digital. Cuando decimos que estamos en todas, es porque estamos en todas. Somos webdental.cl, el medio oficial de la odontología en Chile.
Bueno, hoy tenemos el placer de estar con el doctor Daniele Manfredini para una charla cuyo título es Bruxismo de vigilia. La charla, ¿cierto?, va a ser en inglés, pero con traducción simultánea, la cual será llevada a cabo por la doctora Carol Weinstein. Y para poder escuchar la traducción simultánea en español, el sistema, ¿cierto?, de Zoom tiene abajo un icono que muestra un mundo y que si uno lo aprieta, va a poder hacer la traducción simultánea. Voy a leer ya lo que es el currículum del doctor Manfredini. El doctor Manfredini recibió su grado, ¿cierto?, de odontólogo en la Universidad de Pisa, Italia, en 1999. Tiene una maestría en oclusión y trastornos craneomandibulares en el 2001 en la misma universidad. Tiene un doctorado de odontología de acta en Ámsterdam en el 2011. El especialista en ortodoncia de la Universidad de Ferrara, Italia, el año 2017. Obtuvo un diplomado el año 2021 de la Academia Americana de Dolor Orofacial. Fue becario clínico en la sección de odontología protésica del Departamento de Neurociencia de Pisa, Italia, hasta el año 2005, y desde el año 2006 al año 2016, el doctor Manfredini ha sido profesor asistente de la Facultad de Odontología y coordinador de proyectos de investigación de la Clínica de Trastornos Temporomandibulares del Departamento de Cirugía Maxilofacial de la Universidad de Padova, Italia. Desde el año 2017, el doctor Manfredini ha impartido clases de fisiología oral y natología clínica en la Facultad de Odontología de la Universidad de Siena, Italia, y en enero del año 2017 el Ministerio de Universidad de Investigación de Italia lo nombró profesor titular por mérito científico a la edad de 41 años. Doctor Manfredini es el autor de más de 210 artículos en el campo del bruxismo y trastornos temporomandibulares en revistas indexadas en la base de datos Medline. También ha editado, entre otros, el libro Conceptos Actuales sobre Trastornos Temporomandibulares del año 2010, que incluye contribuciones de 45 expertos de renombre mundial, y es coautor de varios libros de texto sobre los mismos temas. Desde el año 2013, la agencia estadounidense ExpertScape ha clasificado al doctor Manfredini como experto número 1 del mundo en el campo de los trastornos temporomandibulares, y desde el año 2018 también como el número 1 en el campo del bruxismo. Doctor Manfredini tiene un amplio, una amplia expertise, y hoy día entonces nos va a poder hablar, ¿cierto?, de un tema importante para nosotros actualmente, que es el bruxismo en vigilia o de vigilia. Doctor Manfredini.
Okay, here we are. Thanks, Manolis.
Ok, aquí estamos. Muchas gracias, Manolis, por la presentación.
I heard the translator in my audio.
Yo estoy escuchando la traducción y creo que hay un error acá.
Anyway, it's not a problem for me. If there
Pero bueno, no es un
more
problema para
options,
mí.
I can move on. So just let me know.
Así que me dicen, por favor.
In any case, thanks, Manolis, for this very kind presentation. When your society and a representative of your society wrote me about this opportunity, of course, I accepted with enthusiasm, because it reminded me of one of my last, maybe the last trip, intercontinental trip before the pandemic. I was in Chile in November 2019 with Gary Hare, and we had a lot of fun and very interesting moments. I hope
Hablo, aló, prueba.
So today I have been asked to talk about awake bruxism, which is, as you know, one of my favorite topics. So thanks for the introduction. It was really not needed, but it may be useful to give an idea of the pathway that I had the opportunity to have during my career. Concerning the pathway we are going to have in this brief lecture, I had split it in 5 chapters: the definition of bruxism, its etiology, the consequences, the assessment and the possible suggestions on how to manage it, and the STAB research agenda. For the ones of you who are not familiar with the STAB is the standardized tool for the assessment of bruxism, which is the currently under preparation instrumental and assessment tool for the evaluation of bruxism. There is a panel of experts working on that. So today I will briefly introduce you to the behind the scenes.
Sí. Prueba, ok.
No, pues para, ahora.
Prueba, ok.
As you know, bruxism is a hot topic. I still have the translator in my ears.
Dice que me tiene en la oreja.
As you know, bruxism is a hot topic. There are many publications every year. The number over the last 20 years has become 4 times higher than respect to the 90s. And we'll see in the final part of my lecture that this not necessarily reflect also quality of the research we need for better researches. For sure, before getting deeper into awake bruxism and the concepts related to awake bruxism, we need some general concepts about bruxism as a whole, because in the imaginary view of the dentist, bruxism is basically equal to grinding the teeth. So a typical patient with severe tooth wear coming to our office is immediately labeled as a bruxer, maybe a sleep bruxer. Actually, this dental perspective has been pretty much enlarged over the last recent year, also thanks to the works by experts like Gilles Lavigne and Frank Lobezu, who over the years worked on the enlargement of the bruxism concept, the study of the correlates with the other sleep conditions and also the evaluation strategies. And basically, at least in the last decades, we had a couple of milestones that are really important for you to appraise. On one hand, we had an improvement, or better, a standardization of the definition. And on the other hand, the right side of the screen, we had the first steps toward the definition of an assessment tool that is standardized. So we are not more in the era in which certain dogmas about, for instance, in the sleep, the role of polysomnography are considered valid at any cost. But we are entering an era in which we are more open, because according to the definition of bruxism that we will see in a couple of minutes, the number of muscular activities that are defined as bruxism and included in the bruxism umbrella are actually wider than believed in the past. So bruxism is not just the act of grinding a teeth, but it is also a possible combination of other muscular activities like teeth clenching, but also bracing of the jaw muscle. So according to this definition, it is implicit that also the assessment strategies should be, let me say, reappraised to have a better depiction of what is now called bruxism. Everything started in 2013, or actually the year before, because 2013 was just the year of the publication of the first consensus paper based on an idea of Frank Lobezo, who reunited the panel of experts, and we went to work to provide this definition, which to me is the real change of the era in the bruxism field. In 2013, we defined bruxism as a repetitive jaw muscular activity characterized by clenching or grinding of the teeth, and by also the analog activities of the muscles without teeth contact. So bracing is the analog of clenching and means keeping the muscles tense without teeth contact. And thrusting is the analog of grinding without actually contact of the teeth. Also, bruxism has been clearly defined in terms of the possibility of having different circadian manifestations. So not only we have sleep bruxism, but also bruxism during wakefulness. So keeping on considering that polysomnography is the standard of reference just because we can study sleep is a limitation, because with polysomnography we can of course study the correlates of sleep arousals, but we can only measure the grinding or the phasic, the rhythm masticatory muscular activity events. So the sleep bruxism events that are related or unrelated with arousals, but we cannot grasp anything in terms of the background activity, or better, we could, but there are no software yet to evaluate this kind of activity. So within the broader concept of bruxism we introduced in the 2013 paper, it is implicit that we needed to start working on more elaborated strategies to assess bruxism. After some behind-the-scenes debate, we went to work in San Francisco 2017, and it was the first time we entered officially the umbrella of the International Association for Dental Research. Again, a panel of experts invited more officially than what we did in 2012. And basically, the resulting paper is what is now considered the standard of reference in terms of bruxism definition and bruxism construct, and also the possible future agenda. It was published in 2018 in the Journal of Oral Rehabilitation, and it's been the result of collegial work by all the panelists you can see listed in the author list. We had psychologists, orofacial pain practitioners, bruxism experts, orthodontists, prosthodontists, sleep doctors, So it's been a pretty nice work environment, not to say pretty complex work environment. What we did with respect to the 2013 paper, basically we decided to split the definition of sleep and awake bruxism. The two definitions are consistent with each other, which means that they are basically made of the same construct of terms. Bruxism is a masticatory muscle activity first, and it is not a disorder. So bruxism is now considered the sign of something. So saying that the patient is a bruxer is like saying that the patient has a fever, okay, or he's a smoker. The real challenge nowadays is to understand the causes of that fever, which means the causes of that particular muscular activity, and understand if that muscular activity has some possible consequences. That's why it is really not acceptable anymore to consider everything in terms of yes or no, presence, absence, like if we are living in a black and white world. So first message, general framework before entering the awake bruxism world. Bruxism is a muscular activity, MMA, so not the Fight Club, but the muscular activity, masticatory muscular activity, that may even refer as a behavior during wakefulness. So an individual who braces his or her jaw muscles during concentration efforts is actually doing an activity of bruxism. Okay, and if we don't study that, it is really hard to wrap up any possible message concerning the consequences of bruxism, because working just in the sleep environment is not enough to understand what happens in the 24-hour to the patient muscles. And bruxism, as I told you minutes before, is not a disorder, is the sign of something. Within this context, awake bruxism is just warming up, because we have seen that we are now approaching an era in which more than 2,000 papers per year are published in the world of bruxism, but just a bunch of them, I would say 1/10 of them, are related with awake bruxism. So for sure, the evidence we have is really limited. Awake bruxism has, let me say, partially different causes, or partially different etiology with respect to sleep bruxism, because for sure, we know that for all kind of bruxism, dentists should stop thinking that interferences may have a role. But whilst in the world of sleep bruxism, the bruxism generator model is sometimes complex to understand, because we may have sleep conditions that are correlated with bruxism, we may have smoking activities, we may have interaction between drugs, or just the drugs themselves that may attenuate or increase the bruxism activity. We may have neurological disorders, we may have the psyche. In the field of awake bruxism, the psychological perspective is really what matters most. Even if the very first studies on the relationship between psyche and bruxism were originally related to the sphere of sleep. When we reviewed the literature 12 years ago, we found pretty clearly that awake bruxism is associated, in the form of clenching and bracing, is associated with psychological factors. Of course, the quality of the literature was, and to be honest, still is, pretty poor, in the sense that almost everything is based on a yes or no answer by patients on self-report. But this kind of correlation was there. On the other hand, as I told you, the relationship between psyche and sleep bruxism is much more complex. So to make it clear, awake bruxism is something that has to do with the psyche. And we have a pretty fair amount of literature suggesting this kind of correlation. We have papers on experimental wake clenching. We have self-report based papers showing that the more severe the anxiety levels and the stress reaction level, the more frequent is the report of awake bruxism. And all these were concepts we discussed years ago in a very big congress in Europe together with other friends. We published also recently with some Brazilian friends concerning the relationship between awake bruxism frequency and the conditions of the psychological sphere you can see pointed out in this slide: anxiety, depression, and stress, and also oral health related quality of life. Everything seems to be in college students, so we are not talking about patients with symptoms, but also in young adults without any specific symptoms. Everything seems to point out that the frequency of awake bruxism is higher in individuals with certain psychological profiles. Also, there are some interesting experimental studies showing that trait anxiety, which means the personality of an individual who is anxious as a personality, which is pretty different from being anxious in a particular state or moment. Individuals with that trait anxiety have an increased masseter activity when asked to read and to focus on what they are reading. And they also have an increased intensity of awake muscle activity during the clenching episodes while reading. So basically, my point, as the great Chuck Green said, is that we already know that, but sometimes it seems that nobody listens because, to be honest, we published this data more than 15 years ago. Anxiety was really the point in individuals with report of bruxism. And even more than anxiety, I would love to stress the concept of stress sensitivity, which means that some individuals have the tendency to react abnormally to stressful stimuli. That's stress sensitivity, okay? And these kind of individuals are, together with those that have a personality of trait anxiety, are more prone to report bruxism during wakefulness, but in general to report bruxism. And funny enough, when we go measuring the amount of muscular activity, so not just counting the peaks of the events like we normally do with polysomnography and the count of arousal related bruxism events, we showed that the very same psychological features are also responsible for the phenomenon of carryover, which means that some individuals are more prone than others to engage in an increased masticatory muscle activity during the first 1 or 2 hours after falling asleep. Okay, so basically the point is that we have to study the amount of muscle activity to just understand the possible relationship with bruxism, also in the sleep in this case, and the etiological factors. Otherwise, we only have a partial picture. So this was a figure of the paper we published 15 years ago, and we pointed out on the important role of stress sensitivity and anxious personality. So for sure, nothing changed after 2009, after we reviewed the literature available at that time. But the point is, what to do with this kind of information at your side. We will see it briefly in the next sections of my lecture. First, we have to understand how to answer properly when someone asks us, is there a correlation between bruxism and psyche? The correct answer is yes for awake bruxism and is maybe for sleep bruxism. So please avoid a clear-cut answer every time you engage in discussions about sleep bruxism, because the etiology in that case is multifactorial. It depends much on the complexity of sleep architecture, and so it is not really easy to grasp any real messages without having the big picture clear in mind, especially because sometimes we don't even know that some patients may be under treatment with drugs that are known for their potential enhancing or attenuating effects on sleep or awake bruxism. So it is something that for sure, during the oral history phase of our talks with the patient, we should consider as something to investigate. So just to summarize briefly, this slide is a course by itself, and we can see live in Chile next year or next time I will come there to your wonderful country. We could see that awake bruxism is the reaction of a psychological attitude. The type of activity is prevalently in the form of tonic activity, which means clenching the teeth, but also bracing the muscles. It is a reaction to psychological issues, and the consequences, quite obviously, are less related with tooth wear and more with muscle fatigue and TMJ overload and consequently possible pain. So the management, which is causal, is cognitive behavioral. Okay, and that's exactly why also many patients with temporomandibular joint issues benefit a lot from cognitive behavioral approaches. So how about the consequences? When I talk about the panic and symptoms, the stress sensitivity, the total score concerning the anxiety trait in our patients 2005, aren't you thinking about our typical orofacial pain patient profile? I may say that the majority of our patients with pain in the face have this kind of personality, this kind of psychological profile. So that's why we have to start thinking that giving questionnaires, studying the psyche of our patients is not just something that may be useful for research, but it is something that has really strong clinical implications for the management of our patients, because it may be even the only strategy we have to approach the cause of their symptoms. And this is just an example case. I called it Guinness World Record the first time I saw her. A patient coming to our office because she couldn't open the mouth. She felt tense and painful all over the face, basically. A very tough personal period was reported in the history. If you look at the cheek mucosa, it is pretty impressive to see that kind of impression. Also, we have them in the tongue mucosa. So, of course, my strategy here, along with an anti-inflammatory drugs, is to prescribe cognitive behavioral strategies. This is an application we use for, let me say, re-educate the patient and help them acquire awareness of their clenching and bracing attitude, and then to have a potential biofeedback activity. And after the first days, basically, the patient came back to our office and she was always reporting tension, clenching, and any type of awake bruxism activity every time the smartphone sent her an alert. So this kind of psychological tension, of course, is reflected also on an attitude to press and to bite the oral appliance we gave her, and she basically put the stamp or almost created holes in the appliance over just a very short period of time. But the bottom line is that if we don't address her psychological attitude to clench the teeth and to brace the muscles, our clinical approach and our, let me say, way to work within a biopsychosocial frame are crippled. These are just continuous examples of patients with a very high frequency of awake bruxism reports. So they're never relaxed. And that's why they feel pain in the face, because they are overusing their muscles, they are overloading their joints. And it is not by chance that if we are able to suggest him how to reduce this kind of overload, the symptoms improve as well. So the consequences of awake bruxism, but also sleep bruxism, what I'm saying is the psychological related bruxism, is that through an host response, emotions lead to muscle tension, and that's the origin of symptoms, period. Don't take it too complex, the management of the temporomandibular joint symptoms. It is just an orthopedic condition of overload. And if we rely on the literature just using the polysonographic peaks counts of sleep-related bruxism, we cannot have answers, because it is what the patients do 24 hours a day with the muscles that is really important to understand the possible consequences. And in the literature, we already have or had these kind of models discussed and proposed by some researchers. For instance, Alan Glaros worked on the causal role and created, together with his group, a very interesting model for the role of masticatory muscle tension evaluated via ecological momentary assessment for TMJ pain. So how to assess and how to manage these kind of activities? First, assessment should be based on two options: instruments or non-instruments. I really owe an incredible thank you to my friend Alessandro Bracci, who ideated an application to use the ecological momentary assessment approach in the bruxism environment. Ecological momentary assessment means that subjects should report a condition or a state of mood or an action in real time. They, in this case, after Alessandro's idea, they received an alert, via the smartphone, so they are perfectly working in the natural environment, and they have to tap on the display. They have to report on the condition. If they are relaxed, they are clenching the teeth, they are contacting the teeth, they are bracing the muscles, or they are grinding. This was the original and, let me say, old version of the application. I know that Alessandro and his team are working on a new one based on the cloud server and much more functions, and also clinical applicability is on the horizon, are on the horizon. For sure, it's been impressive to work with him, because we have been able to publish lots of paper, and the most interesting one came out 3 years ago, when we shown that the average frequency reported concerning awake bruxism activity by healthy young adults is around 30%, 28.3 specifically in this paper, which is a datum that has been reported also subsequently by other researchers, and also by our same research group in successive papers. Anna Colonna and others also worked on this data. And interestingly, Anna has shown that the compliance of the individuals is also important to understand and to calculate the validity of the report we have, because if the patient is not able to answer at least 60% of the answers, the data are not considerable really representative. Okay, so threshold at 60% of the alerts is based on a scientific paper. After those papers, other interesting data gathered by another PhD student of mine, Alessandra Zani, who worked on the possible biofeedback effect, and showed that after repeated periods of use, and that's the management issue, the percentage of awake bruxism answers diminishes. That means that Alessandro won some prizes in Europe for this idea. That means that this kind of evaluation is not only an evaluation, but also a possible strategy to intervene on the patient's symptoms. We are also working with some colleagues around Europe on the better definition of the strategy to convey the message to the patient, to explain them how to report the condition and how to interpret the questions that are contained in the application. And of course, as expected, everything points toward the feeling that the more the patient use the application and the more information they are given, the better is the reliability of the datum. Together with this kind of ecological momentary assessment for bruxism, ideally we should approach the phenomenon of muscle activities by measuring it. And we have some interesting devices to work in the home environment. Currently, my favorite one, or at least what I consider the most promising strategy, is to work with an halter that is available for recording 24 hours a day the electromyographic activity of the masseter muscle, and not only recording the number of purported bruxism event, but also the so-called bruxism time index and muscle work exerted by the patients. We are working on the preliminary data, so For now, I can only tell you, trust me and trust us, because the information we are gathering with this kind of 24 hours a day monitoring for 5 or 7 days in many patients are really very interesting and have the potential to really help us getting deeper into the knowledge on Bruxismo. So basically, what's new for weight Bruxismo concern in the management is something that is related with the cognitive behavioral strategies that we have already discussed for the diagnosis, because the ecological momentary assessment in the natural environment can also become an intervention, because thanks to the repeated alert and the repeated stimulus the patient receives, it is quite obvious that a biofeedback effect can be achieved. Of course, jokingly, we can also say that sometimes in the clinical setting, the input is just based on the surprise of the patient. I remember the first time I saw a Chinese patient coming to my office and noticing that we had prepared an application working in his language. He was basically already cured and treated thanks to the use of the application. Because what I forgot to say is that Alessandro and his team translated the application in more than 20 languages. Spanish is also available, of course. Sometimes patients give you incredible satisfactions. I think that as in every part of the world, we still have in Italy some crazy practitioners who work with those advancement appliances. In this specific case, it was a young adult who went to a neonatologist to receive an advice because of some mild symptoms in the face. And since he had a click, he received these kind of appliances. Actually, there were no real disc or joint issues. And in my opinion, the real problem was that he was a bracer. So my treatment plan was stop using that absurd appliance and start with a cognitive behavioral approach. And he really got mad about it because for months, you can see he started on November the 17th and he used the application until March the 5th. But you can see that without anything else than stopping the appliance and using the app, the percentage of green in the pie increased and symptoms disappeared. So it is really nice to a certain extent to have such an amount of study on my back in my career, just to give you that the management of temporomandibular joint and jaw muscle condition is much easier than believed in the past, and that most of that management strategies can or must come through the management of muscle tension. And this is one of the goals we have decided to introduce and to discuss in the STAB. The STAB is the standardized tool for the assessment of Bruxismo. You can see the reference publication published last year in the Journal of Rehabilitation. This was just an overview paper introducing the general idea behind the STAB, which is basically a multi-dimensional Bruxismo evaluation system. If you go through the paper and read it carefully, you will notice that we tried to avoid the term diagnosis. Bruxismo should be evaluated, should be assessed, because diagnosis is for a disorder. Diagnosis is for a disease. Muscular activity should be assessed for the etiology, and for the consequence. So we can see the STEP as a sort of a multi-floor also toolkit, depending on the goals you have with your research or with your clinical use. The instrument will be available for assessing bruxism in the form of masticatory muscle activity, gathering information from the subject, from the clinical examination, and from the use of instrument. But it will also be available to gather information on the etiological and risk factors, as also the consequences and the comorbid conditions. So it is basically a sort of helicopter view to comprehend the more knowledge we can. Of course, there's a big team, but more important than that, there are big friends behind the scenes. Without friendship and without trusting each other, it wouldn't be possible to work on such high-profile projects. We went to work also during the summer because the EADR meeting in Boston was canceled on site. So we reunited virtually with the others, and basically these are the official members of the EADR panel. Of course, others are invited behind the scenes as reviewers, but currently our project is to prepare an instrument with 2 axes and several domains, also usable in the form of single kits, single tools, depending on what you need to do. Not so differently from, for instance, the diagnostic criteria for temporomandibular disorder toolkit. You can use the screening instrument, the full instrument, or also some sections. The plan is to meet next year in June. I think it will be virtually again because the next meeting of the EADR will be in China. So I think that for many of us, traveling to China next year will be, let me say, at least bizarre as an opportunity. So I think we will unite again, hopefully for the last time virtually, before getting to work in person in the final refinement phases of the project, maybe at the end of the year in my university in Siena, or in 2013 in Atlanta, Georgia, when we are going to have, in Bogota, Colombia, sorry, when we are going to have the next general session of the EADR, the International Association for Dental Research. So the goal of the STEP, but also the goal of you as clinical practitioners when approaching patients with bruxism, is to try identifying the etiology, to rely on proper assessment strategies to understand the possible consequences. And in the field of bruxism, almost everything points to the importance of psychological issues. So getting to the conclusions, I stayed on time as promised, so I hope there will be questions. Please write them in a chat or in the question and answer or YouTube or whatever you want. I'm here for you. If you are interested in some update on bruxism, there are at least a couple of very interesting papers that we have been invited to write. One for a special issue of the journal Oral Surgery and another one for the Journal of Prosthetic Dentistry. So you can write me privately. I prefer some messenger text and Facebook because it is more immediate to send you these kind of papers, but also you can download the papers by yourself. Before getting to the real conclusion, I would like to stress an important point. I see too many systematic reviews and even meta-analysis on Bruxism. And many of those papers are even authored by authors without an expertise in the Bruxism field. To be honest, this is disturbing because we are doing a lot of fatigue in preparing new researches and in steering the literature and in steering the research goals and the research agenda, and being so inflated by systematic reviews, which are really attractive for the general audience, is not so appreciable, okay? Because my real goal is to diminish the ratio between systematic reviews and clinical trials, which is, to be honest, really impressive. In the field of Bruxism, we have almost 5 systematic reviews per each primary research. So basically, they are reviewing nothing. So if you want to have an easy publication, a possible strategy is to close a student of yours in a library and assign him or her the task of reviewing some Bruxism topic, because you have high probability of getting out with 0 or just a bunch of papers with the typical conclusions that more research is needed. But if you will never do the person who does that research, please stop doing that, because it is not a good service we are doing to the research community. Personal message, as the president of the Italian Society of Orofacial Pain, which is called GSED, the Gruppo de Studio Italiano Dolor Orofacial and Trastornos Temporomandibulares. You are all invited to join our Facebook group, our Orofacial Pain Academy, because there are lots of interactive discussions, not only literature-based, but also clinical-based. And basically, almost all the international experts are behind the scenes of this academy. And there are also a few spots left for this incredible temporomandibular disorders winter camp. We normally have a summer school, but due to the overbooking, we had to organize also a sort of pre-Christmas camp, which will be an incredible occasion to visit Italy if you're interested to join us and to have a real clinical training on this topic. Of course, because before getting to the final slide, I wouldn't be here without all these people and many more. These are just a few ones. So thank you very much. Even if you are not there, you're always been with me, because there are many messages of yours in my presentations. Take home message. So we had 5 chapters in my lecture. First chapter, the definition. Bruxism is not a single entity. So we have to start understanding that we must consider Bruxism a spectrum of different muscular activities that should be measured. Etiology obviously is multifactorial. It is central, so it is absurd to still think about dental occlusion as a possible cause of Bruxism. And the assessment should be based on standardized protocol, which are not the protocol or of Manfredini or Bracci or whoever you want, but they are generated, as normally happens in the field of medicine, by the expert communities. In the field of Bruxism, our goal is to provide you with the step as soon as possible. So, also concerning the terms, it is important that we start at least thinking that we have to phenotype bruxism, because sleep arousal related bruxism is not the same that bracing the muscles during the day. They have different etiologies, they have different sequences, and consequently, they have different management strategies to use. So terms are also important. And then, as you know, my final message is for the youngsters. Life is an opportunity. We should try benefit from it. And the best thing you can do is to study. Thanks to my personal willingness to study, I've been invited in Chile, in Australia, in Canada. I traveled all around the world. So don't waste your time listening to gurus. Take the hard way, study, and you will easily benefit from it. Muchas gracias, and thanks for your attention.
Muchas gracias, Daniel, por tu excelente presentación acerca de lo que es el bruxismo vigil y en general del bruxismo, que es un tema importante. Es difícil de alguna manera, implica muchas visiones y que todavía faltan estudios para poder verificar y determinar bien también de cómo uno puede ir a ayudar a los pacientes que están sufriendo, ya sea del bruxismo vigil o el bruxismo del sueño. Tengo un par de preguntas en relación a lo que es el bruxismo vigil. Yo sé que se está trabajando en la evaluación del TAB y yo estoy escuchando, ¿sí?
Yeah, I can hear you. Yeah.
Perfecto, ok. Perfecto, voy a seguir preguntando. Bueno, en relación al staff, ¿ya? A lo que es el staff, de la evaluación del staff, quisiera saber si es que existe actualmente algún test que nos permita, ¿cierto?, evaluar al paciente como para decir, este paciente probablemente va a tener bruxismo vigil, o todavía no existe la herramienta para poder determinar cuáles son los pacientes que pudiesen presentar bruxismo vigil y poder ayudarlos.
Yeah, that's a nice question. Frankly speaking, this is a sort of black hole in the bruxism literature and also in the bruxism practice, because even when we are preparing, when we discuss how to prepare the STAB, honestly, we have to figure out the best compromise because there is no validated criteria for this approach. My personal opinion, and please take it as an expert suggestion, but I'm not saying that it is the absolute truth, is that you should rely on the report of the patient by asking him or her to use this kind of application on a daily use in a natural environment and report with the smartphone application if they are clenching and bracing the teeth, and that's an option. And then integrate everything or getting deeper after you see that the frequency of report is high with the measurement. Now we are finally starting to have electrodes that are able to record 24 hours a day. But even more important than that, we need software algorithm that evaluate what we call the amount of muscle work. So not just, if you're familiar with the polysomnography, basically at the end of the night of the sleep recording period, you will receive a number, a count. The number of bruxism episodes has been 7, 8, 12 per hour. Those episodes are just the number of events in which the peak of muscle activity overpass the arbitrary 10 or 20% threshold with respect to the maximum voluntary clenching, okay? But doing so, we lose all the background activity that the patient do during the night, but also during the day by bracing the muscles, okay? So we need for software that are able to measure the entire spectrum. And we are approaching this era, okay? So stay tuned, because they are also, at least in Italy, we already have it available for use in commercial setting, okay?
Gracias. Hay otra pregunta y que es, ¿cuál es el dispositivo recomendado para hacer la evaluación instrumental de bruxismo en vigilia?
Basically, I think, Manolis, that this question is partially overlapping the previous one, because I have already answered. We now have these instruments for the 24 hours, so it is ideal for monitoring the bruxismo en vigilia. Okay.
¿Puede ayudar la fisioterapia al relajo de la musculatura y disminuir el dolor muscular asociado a la terapia cognitiva?
Surely yes. Surely yes. And I think it is more or less the same in Chile and in South America. But here in Italy and in Europe, we have more and more physical therapists who claim correctly to have success in the management of temporomandibular disorder patients. So my suggestion is not to rely on strict protocols, on physiotherapeutic approaches concerning the relationship between vertebrae, teeth, and muscle pain, and that kind of stuff. But the muscle relaxation techniques are fundamental. And that's why dentists still working in the field of dental occlusion for managing temporomandibular disorders are completely out of road.
Okay. ¿Qué pasa si es que el enfoque cognitivo-conductual fracasa? ¿Cómo se puede abordar el tratamiento del paciente si es que esto no da resultados positivos para el paciente?
What do you mean, sorry, with fracasa the cognitivo comportamental? Sorry.
Si es que if he failed the therapy cognitive conductual.
Yeah. Okay. Again, everything is based on the diagnosis, because first of all, we should think that we are, I think, at least I am a dentist, okay? Which means that some things can be managed in the dental office, but some others cannot, okay? So one thing is to suggest patients to relax and to work in a better psychological environment, to give some advices and stuff like that. One thing is when you receive in your dental office an individual with a very clinically important anxiety symptoms or depressive symptoms, because it is not a matter that you can resolve just by cognitive behavioral approaches, okay? That's why working with neurologists is important in my experience, and that's why many of us, at least I did it, have taken some course formation, some educational activities like the American Board of Orofacial Pain and stuff like that, to increase our knowledge in the management of pharmacological issues, because sometimes these complex patients are there, they come to the dental office, no one wants to take care of them, and we are ethically obliged to do something. And cognitive behavioral approaches are not enough in some occasions.
Última pregunta que tengo es, ¿se han determinado algún parámetro de apriete fisiológico y patológico?
De apriete?
Apriete, clench, physiologic or pathologic.
Okay, we have parameters in terms of reported frequency by the patients. We don't have parameters in terms of muscle force, which is another weakness of the Bruxismo literature. In terms of the report of the patients concerning wakefulness, we have, as you noticed in one of my last slides, that 30% is more or less the acceptable quote. You can stay pretty sure that when you have a patient who report that 70% or 80% of the times is contracting the jaw muscles, you may have some clinical consequences. Okay, when you stay in the range of 30, 20, 35%, that's what we found in the healthy young adults. Concerning the sleep, the only way we have to establish parameters is to work with the measurement strategies, so the electromyographic recordings over the 24 hours, and split the activities between sleep and wakefulness, and then create some possible parameters evaluation. That's fancy. Sorry for taking this time, but I think it is really important to give you a message as one of the leaders of the Bruxismo and neurofacial pain field. I think, Manolis, that in the field of temporomandibular joint disorders, we know a lot. I'm giving basically the very same course year after year, because there are always dentists who want to know why occlusion is not important and stuff like that. But in the field of Bruxismo, I think that the information I'm giving you this evening will be partly different 5 or 10 years from now, because there is a constant evolution. And for a researcher and an open-minded clinician, that's fantastic.
Muchas gracias, doctor Daniele Manfredini. Un gusto y un placer tenerlo de manera virtual. Ojalá que pronto pueda viajar a Chile, ¿cierto?, a hacernos alguna charla tan interesante como la que tuvimos ahora con usted, ¿ya? Muchos agradecimientos y que esté muy bien. Buenas noches, que tenga una buena cena.
First, I have to take dinner, okay?
Perfecto, sí. ¿Ya?
Okay,
muchas gracias.
Thanks again, muchas gracias. I really enjoyed this time, and I hope to meet you personally again in the future, okay?
Okay,
bye bye.
Muchas gracias, que esté muy bien, hasta luego.
Ciao, ciao.
Chao.
Años, informando a los dentistas de Chile y el mundo. El entrevistas, fotografías, sitio web de noticias, cursos, videos corporativos, simposios, periódico, impreso y digital. Cuando decimos que estamos en todas, es porque estamos en todas. Somos webdental.cl, el medio oficial de la odontología en Chile.